Okay, I'm going to talk to you about the 3-site Mayo Clinic experience on median arcuate ligament syndrome, which is a really challenging disorder. Since it was first reported in 1963, the author stated that compression of the celiac artery by the median arcuate ligament rises to both neural and vascular phenomena, which combine to produce a clinical picture. Very confusing from its inception. The best real data that we have on the disorder really comes from an anatomic dissection in 1971, and we really haven't progressed that much beyond that, where you find that the median arcuate ligament is really a nest of lymphatic and autonomic nerve tissue and diaphragm muscle that really encases the celiac plexus and celiac artery. Anatomic dissection revealed a full 26% of all patients have the median arcuate ligament lower than the celiac origin, and that the closer the median arcuate ligament is to the celiac, the higher the likelihood that the inferior phrenic arteries arise from the celiac, whereas very low likelihood when you have a high median arcuate ligament. In a Turkish population, a full 4.5% on CT angio have some compression of the celiac by the median arcuate ligament. And that can be simple compression that's dynamic with expiration. It can be associated with poststenotic dilation or even an aneurysm changes. And that there's a general female to male ratio of 1.6 to 1 in those who have asymptomatic compression. And in those who have symptoms, it's about 6 to 1 female to male. Zalagi, very famous vascular surgeon, really questioned it and said that on the whole, one becomes increasingly impressed by the inconsistency of the clinical picture, the paucity of objective findings, and the logical contraindications of the theories behind this. So he felt it really didn't exist. Now, we know that there is a pain syndrome, postprandial pain, post-exertional pain, nausea and vomiting. And the Australian experience found that they had the best response when patients had some component of post-exertional pain, because there's so many other things that go into postprandial pain, so many other diagnostic implications of having gastroparesis or dyspepsia. So the pathophysiology really combines some vascular phenomena, some nerve compression phenomena, some psychiatric phenomena. And these patients kind of tend to reside in here, having some neuro findings, some psychiatric findings, and some vascular findings. And we'll try to distill that. So is it a psychiatric